All right, welcome everyone to our last Schools Teacher Education Colloquium series for the year, but also for the semester. Our talk this time is by Dr. Jennifer Perry, Teaching Faculty 1 in the Visual Disabilities Program. The title of the talk is Vision Loss Insurance. A little bit of a brief bio about Dr. Perry. Dr. Perry has been an advocate and in the field of blindness since 2005. Since then, she has worked in nearly every aspect of blind rehabilitation with every range and level of ability within extensive regions in the United States and abroad. Dr. Perry is proud to be a member of the FSU community of scholars and hopes to use her position to increase awareness of blindness-related issues, not just in education, but also for the lives of individuals who have vision loss into adulthood. So Dr. Perry is going to have her presentation for about 30 minutes to 35 minutes, and we will leave the Q&A until after the presentation. Feel free to use the chat for any questions that you might have, and then we'll make sure to address them after. So Dr. Perry, it's all yours.
Thanks, Amal, and thanks everyone for being here. This is a really exciting and passionate presentation of mine. And I can just kind of give you a little background about where it comes from. When I was still working in the field, I was working at a nonprofit agency called Columbia Lighthouse for the Blind, which was funded predominantly by grants, because a lot of times the state dollars that were being used to fund services for the blind, for older adults and even for working age adults, that money was sometimes limited. And I had a CEO at the time who was asking me, what did I think was something that would be a little bit more sustainable? How could we sustain blind rehabilitation services in a more longer term outcome rather than grants and charity? And so this was my proposal back then. And since then, I had a chance to do some research on it while I was pursuing my doctoral degree, and then create a presentation about it. So I've shared it already at one professional conference recently, and it can be viewed at AER e-learning. And I'm really happy to be able to share it with you here today again. So yes, it's called Vision Loss Insurance. And we're just talking again about how the rates of vision loss are rising across the world, not just in the United States, but globally. What are some of the impacts to the individual and to society when we have members of society who have visual impairments? Some of the current dilemmas associated with vision loss and with providing services, and then how we might reimagine our future by having insurance, something that currently does not exist. So in the introduction, vision problems in the United States are rising. We have a projected doubling of visual impairments in this country from approximately where it is now at about 8 million individuals to about 16 million individuals by 2050. This is just an estimate. It's one of the lower estimates. There are some projection models that actually have higher numbers, more like 32 million Americans by that time. And so without implementing some strategies to ameliorate quality of life through access to rehabilitation, medical intervention for the individuals and their families and communities, this can have a negative impact on all of society. So some of the factors that lead to blindness and vision loss. Some things that are somewhat controllable and somewhat not controllable at the same time is aging. So we all grow older, and some of the conditions that are common to blindness are directly impacted and have a higher propensity when individuals get older. Over the age of 55 is when certain conditions really start to become more dominant. Also diet, not having nutritional access. And another really important one is just not having access to your health care. So if you have insurance and you have vision insurance and you're going to your eye doctor every year and you're getting your pressures checked and you're having your glasses updated and things like that, that is a luxury that not everyone has. Not everyone in the United States and not everyone in the world has access to that kind of healthcare. So a lot of times I'll give this presentation or talk about these things with individuals who are more in the blindness community and vision loss community. And so I have this question here about what other factors that you can think of. And I'll just kind of skip that for now since we have a shortened presentation, but maybe keep it in the back of your mind. What are some other things that might lead to blindness, including stroke, car accident, traumatic accidents, things like that? It's not just disease, right? So some instances of blindness are preventable. If the preventative services are available, then early detection can help to stop blindness from progressing. In some cases, it can even stop blindness from happening. If remediation services are available, like surgery, glasses, and if you have that ability to change your lifestyle, for example, eating better, not being homeless or on the street, right? Some of these things are preventable, some of them are not preventable. So if you have the ability to change your lifestyle, then also this can help with your risk of blindness. And how does healthcare access play a role? So we know that some countries have universal healthcare access, but we also know that some countries don't really have any healthcare access, or it's much more limited. And in the United States, it's kind of hit and miss, right? The United States healthcare system is available to some, but not all, right? So if you have a good job, that proverbial good job, then you probably have good insurance. And if you don't have such a good job, maybe you don't have any insurance. So even when it is available, that means it's often optional. You can opt out of insurance even when it's available. When you are selecting insurance, it has different coverages, different tiers. There are varying rates that you have to pay for these services. And across the United States, not all services are available in every state. And also not everyone qualifies. And then of course, not everyone can afford it. A lot of people choose not to have insurance because they can't afford it. Related to vision insurance. Vision insurance is usually separate from your medical insurance. And this coverage also can vary. Certain vision insurance coverages may be just for your preventative care, or maybe it only covers glasses, or maybe it only covers surgery. You have to look at the fine print to find out what your insurance actually covers. But higher premiums, again, will cause some people to choose not to have insurance. And a lot of times with vision insurance or with vision problems, people don't sometimes tend to go until there's a problem. And what happens with vision loss is that usually if there's an evident problem, a lot of times it might be too late at that point. The other concern is that when people go to visit the doctor, sometimes those doctors don't know that rehabilitation is an option. So one of the things that we do here in the Visual Disabilities program is that we are training rehabilitation professionals, right? We're training teachers with visual impaired, we train orientation and mobility specialists, and there are other different kinds of vision rehabilitation professionals that exist, so that when someone does lose their vision, they can have treatment and they can have care and they can have help. But sometimes if the doctors don't know that the rehabilitation is available, what we'll find is that the doctors will say, you're losing your vision. There's nothing more I can do for you as the eye doctor. So now you just need to go home and live your life as a person who's blind. And they don't always tell them about all of the wonderful rehabilitation options that currently exist. So the rates of blindness and low vision really could be mitigated just by having access to preventative care. They could also be mitigated by doctors knowing that there are services available. So who's most at risk? Persons in poverty. And this kind of goes without saying. This is the nutritional deficits the most limited access to the preventative care for a variety of reasons. And then persons who are at risk for trauma or other diseases, like those car accidents, stroke, sports players, right? They get hit in the head with a baseball or something like that and causes their retina to detach. AMD is a few letters that stand for age-related macular degeneration. We also have glaucoma, diabetic retinopathy, and cataracts as our big four. These are some of the biggest causes of vision loss in the United States today. So what happens when you realize that you've lost vision or that you're losing your vision? We have a couple of different current models of care. And in the educational system, this is for kids in the K through 12 environment. This training is free, okay? And it's offered to kids who are in school. And I put this in parentheses, if there's a specialist in the district, because sometimes a school district doesn't have a specialist on their staff, meaning that the student who's visually impaired is not getting the services because there's no specialist available to serve them. And of course, one of the things we're doing here in the Visual Disabilities Program is doing our best to put as many specialists out there just as fast as we possibly can. And so when the kids are in school, we've got the TVIs, the teacher for the visually impaired, and the orientation and mobility specialist. We're meeting the ECC, and these are all words some of you probably haven't heard of, but it's called the extended core curriculum for our kids in K through 12. In the rehabilitation model, which is going to be more for our adults, we are assisting in the transition for these kids who are in school as they come into the adult models of care. These use state disability dollars. It's heavily reliant on grants. And then for adults, the orientation, mobility, and then these other letters, vision, rehabilitation, therapy, VRT. Those services are typically provided by nonprofit agencies or other state agencies. When a person needs devices and training, some of the specialized equipment that we offer that's available for people who have visual impairments, either those clients have to pay for them themselves, or sometimes the state will buy it for them. One thing that's not listed in this current models of care is the VA healthcare. So for people who are veterans, the veterans have their blind rehabilitation services integrated into their healthcare, meaning that if you're a veteran and you lose your vision, you can go to the VA hospital and receive devices and services essentially at no cost to you. So this is the contrast between the rehabilitation model, because in the rehabilitation model for civilians, non-veterans, you either have to pay for it yourself, and in some cases they can be provided to you by the state. So again, in this rehabilitation model, we have the state allocating funding from its general revenue to the disability dollars. So you've got all of the taxpayer money coming into a disability pot of money. And in Florida, that's approximately $95 million. Also in Florida, this money is used to serve about 58,000 people. And this is with all different kinds of disabilities. So if you apply for disability services with the state of Florida, it could be cognitive disabilities, physical disabilities, blindness, anything that qualifies as a disability. People could apply to receive some of this $95 million. And in Florida, we know there's already a waiting list, and there's not enough money in that pot either to reliably help everyone. So this means that there are people who are getting either turned away or in some cases underserved. So looking at the budget, every state has a similar model of disability dollars for their adult rehabilitation. With more people with disabilities, including blindness, and the rising cost of healthcare, not everyone's getting helped, and the money that goes around is being reduced. So the states will triage their citizens, providing services sometimes only to adults who are working age. So from just a few minutes ago, we're talking about, at the age of over 55, this is when a lot more blindness related issues might become prevalent for our citizens. But if that person loses their vision and goes into, say, a retirement, then they wouldn't be able to get help in order to help them live independently, for example. And then they might have to go into a home, or some kind of center instead of living at home, which they would be able to do if they had the training, rehabilitation training. So this means adults still have to buy much of their own assistive technology. And even if they were to buy it, there's not always someone to train them on it. And assistive technology in this country it's pretty expensive. Some of the devices are a little bit more reasonable, $100 or $200, but software is up there at $2,000 for one license for 1 year. And so even if they have the money to buy the assistive technology, it doesn't always mean that there's someone there to train them on it, because the trainers are also not covered by insurance, right? And just kind of in this model of, if you break your leg, for example, and you need a physical therapist, the physical therapist is your trainer, right? They will give you your crutches or your wheelchair or your prosthetic leg or whatever it is that you need. And then they would provide someone to help you learn how to live your life and adjust with this new physical disability. But what we're not seeing in blind rehabilitation is the same kind of ability for devices and training to be offered to citizens. So again, some disability groups, like people with some of these physical disabilities, can receive their devices and services from their insurance benefit. When covered by insurance, the devices and services that they receive are not coming out of the state disability dollars, right? But because there's no vision loss insurance, all devices and services for blinded adults do come from that disability fund. And now for over a decade, Florida's Agency for Persons with Disabilities has been running way over its budget. And these are quotes, if we don't make these changes, the whole thing, the whole system is going to collapse under its weight. This was just from January of 2020. So some things that we might want to have covered by insurance could include the rehabilitative training, how to live independently as a person who is blind, all different kinds of devices and strategies for independent living, learning Braille devices, a Braille teacher, talking computer software, computers that talk to you, someone that can train you on it. iPhones have talking GPS, all kinds of different assistive technology that's already built in. Someone could show you how to use those things. Even the white cane, which is probably the most emblematic symbol of blindness, is not covered by insurance, right? If you lose your vision, you can't even get a white cane from insurance. And what I like to kind of remind people is that probably most people don't even know how to get a white cane, right? I mean, if any of you lost your vision tomorrow, would you know where to go get a cane from, or who to call to get services and training and things like that? And then what would happen if you called to get that kind of training and someone said no, right? What would you do? I'm also going to skip over this Slido. So the next thing about the next part of this slide, I'm going to move really quickly through because I know we're on shortened time. But just in general, back in the 60s, Reverend Thomas J. Carroll, he was a writer who talked about some of the personal losses that an individual might go through if they lost their vision. And sometimes it's things that people haven't necessarily really considered, right? And like I said, I'm going to move through these pretty fast, but loss of physical integrity, the loss of confidence in your remaining senses, the loss of reality contact with the environment, visual background, light security. Some of these things might not make a lot of sense, but just in general, especially with this last one, when the light is on, sometimes people feel safer, more at ease. When it's dark and you can't see real well, sometimes people are just feeling a little bit more lost or scared or unsure of themselves. You know, so you hear a bump in the night, you want to turn the light on. If you lost your vision and the ability to see light, you've lost your light security. And that's, you know, kind of what that's talking about. Your loss of mobility, your ability to get around, all different kinds of techniques of daily living. You might even lose your ability to write, use your handwriting, and the loss of ease with spoken communication. So you can't necessarily see somebody else's facial features or gestures. Loss of informational progress, spatial updating, loss of recreation, things that you used to like to do. You might have lost your career. You might have lost your goal. You might have lost a job opportunity. And all of that could also result in a loss of financial security. And together, these things can impact a person pretty greatly, right? In terms of a loss of your own personal independence, social adequacy, loss of obscurity, another one where if you did have a cane, suddenly everyone is going to draw their attention to you, right? You're going to stand out from the others by holding on to this white cane. Or if you're bumping into things, or if you're tripping over things, or if you look blind, and I'm saying this in my air quotes, right? Sometimes people will draw attention to the things that are different. So again, loss of total personality, the organization of your personality, everything about you might change. You'd be unable to appreciate the things that you used to appreciate visually, sunsets, so forth. And so it goes without saying that visual impairment has a major influence on one's health and quality of life, okay? So the advocacy for the need for rehabilitation, I don't think there would be any doubt that we need to have rehabilitation for people when they lose their vision. But in your mind, is it something that should only be provided if there's enough money? And how can we make it more available to everyone? And then the other side of this is that just because the sensory impairments diminish the quality of life for the individual, there's converging evidence to show that that vision and hearing loss can have additional cascading consequences for patients' families, caregivers, and society. So if I've lost my vision suddenly, it doesn't just impact me, right? It would impact everyone around me, my students, my job, my coworkers. I wouldn't be the only person who was impacted by this particular loss. And at the moment, we've got some pretty disconnected services that are out there. So if you're a medical provider and you do know about rehabilitation services, a lot of times these providers are going to refer in network. These are terms that people who have insurance are probably pretty familiar with, your in-network providers and things like that. But blind rehabilitation currently, since it's not covered by insurance, therefore there's no in-network to have. So because it's off the radar like that, that's another reason why services could be ignored. And again, the doctors would just say, there's nothing more I can do, right? It's time for you to just go home. I'm sorry, I can't improve your vision. What would be helpful is to have a way to connect the services so that the vision providers, doctors, could understand that the vision loss is what it is, and to make the appropriate referrals to the rehabilitation agents, because it is a health-related issue. And so these systems should be connected. And of course, I'm not saying this. This is from Willick, Shane, and Davis. I think I missed one here. Some other processes at one time were not covered by insurance, but they are now. And a couple of examples that I had pulled out from here are acupuncture and in vitro fertilization. These are just two examples of things that at one time were not covered by insurance, and now they are. And so they had to go through a process in order to get to this point. And so just a couple of steps that I was able to find in their process included defining what it means to be a practitioner, recognizing the specialized training, having a membership in professional organizations, achieving licensure, and attempting to standardize practice. Okay, those were some of the milestones for acupuncture as they went through their process. And then some of the arguments for advocates for in vitro fertilization to become added as something to be covered by insurance are some of these statements. Women undergoing infertility treatment can experience feelings of anxiety, depression, and distress. Women who are infertile, they have the inability to achieve their socially desired goal of motherhood, and this can lead to psychological distress. Infertility not only puts a psychosocial strain on the individuals diagnosed, but it can negatively impact couples' relationships, okay? And what I'm drawing your attention to are these similarities to vision loss. These same arguments, if you change the words, really could apply to vision loss. And so women and men who experience blindness experience feelings of anxiety, depression, and distress. Okay, this is from American Foundation for the Blind. Many women and men with blindness report psychological distress. This is Carlson, 1998. Blindness not only puts a psychosocial strain on the individuals who are diagnosed, but it negatively impacts couples' relationships. This is Strawbridge, Walligan, and Shima, 2007. And women and men who are blind often experience the reduction in quality of life. Therefore, it's essential to provide rehabilitative care that leads to education, work, and social activities. This is Rappaport, 2015. These psychosocial factors, such as anxiety, have physical and psychological components, and therefore, these complementary therapies have the potential to reduce the anxiety. Do we think that this quote is or could be applied to vision loss? You lost your vision and you're experiencing anxiety. Would a therapy, rehabilitation therapy, help to alleviate some of that distress? And I just want to put this disclaimer out here that I definitely support the psychological health fully 100% for women and families who experience infertility. I just also hope to extend the same insurance luxuries to those who experience vision loss. So some additional potential research that we could look at is that back in 2014, Whitson and Lynn were talking about the lack of high quality evidence remains an obstacle for other policy decisions regarding sensory impairment. The U.S. Preventative Task Force has not issued a recommendation on screening for visual acuity or hearing impairment for adults, citing inadequate evidence to assess the balance and benefits of harms. And those are a lot of words that basically are saying the U.S. Preventative Task Force does not see the benefit in preventing blindness. They don't seem to know that not doing so, not identifying and helping to rehabilitate persons with blindness could be harmful to society. Okay? So in order to prove the case, possibly it would have to be shown that the individual who is screened for sensory loss would benefit not only from being identified, and that society could be harmed by not being identified and by allowing the blindness to continue without intervention. A couple other barriers that we have here: lack of accessible eye clinics. So if you lose your vision and you need to get to the eye doctor, how many of you know for a fact that your eye doctor is on the bus route? Right? Just for example. And then of course we have that lack of universal health and vision loss coverage because it's optional and it's not even vision insurance is not available in every state. And of course, vision loss insurance is not in any state, right? If we were able to get it added to Medicare and Medicaid, I'm talking about vision loss insurance, not all providers accept. Medicare and Medicaid. And then there's, of course, this lack of telehealth options currently. I think because of COVID, we are getting closer to having more options in that way. But there could be more, especially for people who can't make it to the actual doctor. So vision care is commonly neglected in the healthcare system. It needs to be addressed. If we bundle services and stay underinsured, not have access to the eye clinics, vision coverage is optional, and showing no real benefit to the early detection, these are all substantial barriers that we have to overcome. And it could be our job to prove that being identified as a person with a visual impairment and providing all those needed and necessary services benefits not just the individual, but also society as a whole. Skip this slide 02 and move just right to the summary. So based on this and the substantial number of individuals who need services now, and considering the projected rise in individuals who will be in need of blind rehabilitation services and devices by 2015, evidence is compelling. So, thank you very much.
Thank you, Dr. Perry. We can open it up now for questions from the group.
Who wants vision loss insurance? Who knows people who can help it happen?
Hi, this is Kay Holbrook.
Hey, Kay.
Thank you. Hey, thank you so much for an interesting presentation.
Thanks for being here, Kay.
Oh, my pleasure.
Wow.
So my question is, you know, we've talked about this for quite a while, and I think that those of us who are in the field and see on a daily basis examples of people who would really benefit from support that they're not getting are pretty frustrated. So what do you think the next steps are? I mean, what can we do differently that we have not been doing to make sure that your dream and your passion are realized?
So that's a great question, Kay. And I, play around with this in my mind all the time. And just so everyone knows, I mean, Kay is a pioneer and a wonderful advocate in the field of vision loss. Are you in Vancouver?
I am. Yep.
Okay. Yep. At the university up there in visual disabilities.
Yes, but I graduated from Florida State, so my PhD is from FSU.
Congratulations. So it's great to see you here. Kay Holbrook has actually even written some of our textbooks that we still use, and it's just an honor to even be talking with you today. So thank you so much for your question and for your passion in this field altogether. But one of the things that I would think needs to happen, of course, is for the right person to hear these ideas. And as someone had mentioned in the chat, presenting to the legislature. And I think that's definitely one of those next level steps, is to make a presentation to the legislature, state representatives, national representatives. We have just now, very recently, there's a TVI who's in our United States Department of Education. We have an O&M who's in our United States Department of Education. And this is just within the past couple of years. And hopefully some of that influence will trickle down. So
good. Yeah. I think you've hit on the right, at least part of the right solutions.
Thanks, Kay. Yeah, I'm happy to talk with you more about CNIB or how we can connect some of the services too.
Jennifer, you mentioned the chat. Are you able to see the questions that are there?
I saw one at one point from
From Christy,
Christy.
yeah. Denise asked who are the people that can make this happen, and then she also asked if blind organizations have a strong lobbying force.
They don't seem to have as much of a strong lobbying force as I would expect or hope. Some of our larger groups are AER and ACVREP. I know AER is fully behind this endeavor and has made some progress with sharing the presentation that was recorded at a Mississippi AER conference, and also have talked to some other on the ground type of individuals who are having the same mindset of how can we connect these services. So it's a slow process. Our field is really small, and we're highly taxed with lots of things happening all the time. So we're just trying to keep on top of it all.
Jennifer, as you were talking, it dawned on me that, I mean, a lot of what you talked about also is applicable to people with other types of disabilities. For example, kids with physical disabilities often run out of enough insurance to continue to pay for their healthcare needs. They max out their adaptive equipment and so on. So I wonder if vision joining forces with other disabilities might increase your advocacy potential, and then the possibility of some disability as opposed to just vision insurance might be more useful.
Well, Mary Frances, I love that idea. And I know I've talked with Kathy and a few others from time to time about the connection between, especially orientation and mobility, and other what they call related services, like speech and language, physical therapy, occupational therapy, and how those things are very connected, because especially with our services, they apply not just for kids in school, but they also extend into working with adults. So teachers for the visually impaired tend to work only in the schools, but O&M, speech, PT/OT, they'll work with kids who are in school, but then they also work with them after they get out of school, or if they don't have issues until later in life. So I agree with you. That's something else I'm passionate about, is making a greater connection between those related services, between and among those related services. Absolutely. So, and I think here at Florida State, we've got one other related service. Of course, it's not in our college, it's the speech and language. And I'm not sure what college they're in, but they are here somewhere in Florida State.
Well, and we also have some connections with the OTPT school at FAMU too. So
great. And I know, especially, Dr. Bischoff and I have talked about reaching out to them as well. So. Welcome from Kosovo. Amazing. Thank you for being here. So yeah, presenting to the legislature, talking with other state representatives, trying to bring some more people together. Those may be the people who can make it happen. Possibly even just talking directly to insurance companies. From time to time, especially recently because of COVID, I've seen either on the news or random places, they'll say, because of COVID, now such and such a service is covered by insurance. And I always think, well, how did they do it? Who did they talk to? How can I get in touch with them? It's probably not just a phone call, right? Hey, can you add this? If only it was that easy. Oh, thanks, Nicole. College of Communications and Information, she says, is where speech and language is. But yeah, I'd like to make connections with them and with the folks at FAMU, and just kind of see how we can connect forces a little bit.
I have a question.
Yeah.
Dr. Perry, thanks for all the information. What is your guidance to schools that, I know the district or the county seems to have a department and they're set up, but for those schools that are outside of the district, some of your charters, what is your guidance to them when they have students that may need those, supports? And I know I gave you a little bit of information Before, like I've heard some schools will just say, look, we can't support you. We don't have those supports here. You have to go somewhere else. But I'm of the mindset where, you know, we can, if you were to walk into an administration, is there some place you can refer a school to be able to get set up, you know, to provide those services for students?
Sure. So, I mean, it's really kind of tricky with those charter schools because they don't have the same mandates, you know, under FAPE that public schools have. And so, like you're saying, they're given a lot more free will to just deny the admittance of students because they're not under that same mandate. And mandate, you know, from IDEA and, you know, FAPE for free and appropriate public education. Those only apply to public schools, you know, not in some. So she says public charters are not exempt, but they exercise this right on a fairly regular basis to deny students from entering. So if they do have a student in the school, and of course I've worked with charter schools, you know, if they do have a student who's attending that school, it's not like they're not allowed to have services. Where do they get those services from may be different. So for example, when I was working as an orientation mobility specialist at a charter school, I would just go into the school and see that student. Florida has a little bit of a I could call this a barrier to some extent as well in terms of orientation mobility, because Florida has another level of legislation that says orientation and mobility specialists in Florida have to also be teachers of the visually impaired in order to go work in a school. So for example, probably here in Florida, since I'm not a TBI, I probably wouldn't be able to go work even if I was available. And a lot of times the individuals in Florida who work at Lighthouse for the Blind or adult rehab centers, they might be an orientation mobility specialist, but they're not a TBI. And so in some cases, then they wouldn't be allowed to go and provide services, even though nationally they're allowed. It's a Florida law. So Florida's got some interesting, tricky, fun, not so fun.
It's like we have ways to go to catch up, sounds like, as well.
Yes. And I know Dr. Bischoff might be able to speak to that a little bit more, you know, being, you know, from the Florida public schools. But for myself, not being from Florida public schools where those kinds of things are not law, I know it was strange for me to hear. Other questions or comments? Well, I can make a comment. Today is the International Day of People with Disabilities, which is a international celebration for people who have disabilities. And today is celebrated globally. And they have a theme every year. And this year's theme is fighting for your rights in this post-COVID era or post-COVID landscape. Although I kind of question if we're really post-COVID at this point, but I think the message of fighting for your rights at any time is relevant when we're talking about people with disabilities all around the world. Something that is definitely true, that even in the United States, where we're talking, we've got a long way to go and we're, you know, on an uphill battle and we've got, you know, different laws maybe that have to catch up. We are still over and way ahead of several other countries. And I think that's, you know, important to say, like, this isn't just heavy criticism on the United States. Like I also want to acknowledge that the United States has done amazing things for people with disabilities in this country, right? And other countries do look to us to try to develop laws and models and standards of care for their people who have disabilities. But I think if we look at the history of people with disabilities, you know, even in this country, it starts out as that small group of people who are fighting for their rights, right? They have to know what they are even asking for. And that's something that I did. Fortunately, you know, when I was visiting other countries, I would talk to them about what kinds of things are available in the United States so that they know what to ask for, and how the laws are written in the United States so that they could try to emulate that in their own way, because of course their governments are not at all set up like they are here, you know, but they can write it in their own way. So, but it has to do with bringing people together, having people who have that same mindset, having the collaboration, and it takes a lot of time and a lot of patience, and in some cases a lot of money. So yes,
I'll,
Kay?
I found that the discussion just a minute ago about schools was really interesting, and it did make me want to, I don't know if this is a comment or a question for you. I'd love to hear your perspective on it, but we really struggle between a medical model of disability, but also vision loss for sure, and an educational model or a social model. And it would be scary for me if this insurance had an unexpected consequence of saying to schools, oh yes, you don't have to provide educational service because this insurance is going to take care of providing what really should be teacher-based education instruction in schools. So do you have any thoughts about how we have to navigate that very scary minefield to make sure that we don't do something that benefits one cause but is a challenge for another?
Yes, and thanks again, Kay. So I definitely have thought about this as well, in a couple of different ways. And it usually goes back to the connection between the OTs, the PTs, the speech personnel, who they're able to go into the schools and see their kids because that's part of FAPE and because it's assigned as part of those related services. So they still do provide those services to the kids. And it's just that when they get out of school and they get into the adult world, if they still need those services, which so often happens, especially with vision impairment, now where are they, right? So with the other related services, they have insurance models that can pick up. And I can even say, you know, during COVID, for example, when some of the schools were shut down, right? Private practice OTs, PTs, and speech were still able to see their students by having them go to a clinic, but orientation mobility services were absent, right? They were completely absent. And it has had dramatic impact on, you know, you're in the university internships, right, for our students. And so here in Florida State, you know, we're experiencing that, you know, post-COVID, current COVID, you know, from last year and, you know, leading into that and even now. So there's that. And then the other thing that may or may not be interesting to anyone is that when I did my dissertation, which was just last year when I finished it in 2020, I was looking at adventitious blindness, and I did a phenomenological inquiry, and, you know, to try to find out what are, you know, the common themes. And the one thing that everyone had in common is that their vision loss was a medical condition. So there is, I mean, of course, there are other ways to lose your vision through traumatic accidents and things like that, but predominantly vision loss is a medical disease or condition that happens to the structures, the anatomical structures of the eye, or the structures of the brain that causes it. So I think that there is and can be an argument for the connection between vision loss and a medical model, as well as an educational model. So I guess both. And the way that it's currently set up as both in other related services, occupational therapy, physical therapy, and speech, has not stopped services from occurring, and which makes me feel like it wouldn't stop services occurring for kids who are blind either. That's my thought.
Thanks very much for your comments.
Thank you, Kay, for asking. And then there's a question in the chat. It says, thinking about the white cane, what are the difference between this and other canes? And what would be the benefit of someone having this cane versus others? So the white cane, let me grab one. I have an office full of them. Ta-da! I don't know how much of it you can see, but the white cane is designed to have this red tip on the bottom. I'm not sure if this is in the image, if you can see it or not, because I can't see the camera. But the red and white cane is actually this international symbol of blindness. And so when somebody has this cane, it is used to identify them as a person who has a visual impairment. And what makes it different from other canes, and what I'm thinking of are support canes, walkers, rollators, or other types of physical support type devices, and let me know if I'm not addressing your question the way that you intended it. But the white cane is not designed for support. The white cane is designed to preview your environment. So it lets you know if there's something in front of you because you can't see. So you're holding it out in front of you and you're moving it back and forth so that you can feel texture changes on the ground. You can feel if it bumps into something, and it lets you know that there's something in front of you so that you might have to walk around it. And then of course, it lets you know that the person carrying this cane is a person who has a visual impairment. So other types of canes don't do those things, if that makes sense. And I hope I answered your question. Christine, I'm reading your comment. The view that blindness is medical is fascinating. My dad is late. Oh, it changed. My dad is late life deaf, and my parents have become ardent supporters of framing deafness as cultural rather than medical. How interesting. I guess this is due on the impact between language and communication. Oh, I really couldn't get into all the details between the deaf community, capital D, and the blindness community. There are many, many, many distinctions. Many. I understand all, those arguments too. I do. And maybe it is, more communicative. Losing your vision, as I shared from the presentation, has all those substantial losses in your life. Losing your hearing maybe doesn't have the same level of losses, requiring the same level of intervention. I hesitate to even really answer fully on it because it's complete speculation.
My understanding is that the loss is very social. Like it's deeply, deeply isolating to lose your hearing, particularly late in life, because you can no longer, like if you lose your hearing early in life, you can build a deaf community. But if you're late in life and no one around you speaks sign language, you're isolated from everyone around you.
Oh yeah.
I think a lot of that.
Use your computer is what I'm thinking, right? I guess you could still get on Facebook and things like that. If you, this is, again, just talking. If you lost your vision and couldn't see your computer anymore, it changes the way that you communicate with others.
I think I don't know anything about this, so take it for what it's worth. But I think from my experience when I was living in the UK, that people that look at it as a cultural matter, the medical model says, okay, this is, you've got a problem and we can try to fix it, kind of thing. Where when you look at it from a cultural perspective, the disability isn't the person's, it's they're being disabled by culture and the way that society is functioning, and that therefore the treatment of the disability or the management of it, and I'm sure I don't have the lingo down right, but that it's a societal matter that society needs to come around and make things, organize things so that these people are no longer disabled. And I'm not sure that that's what Christine's talking about, or her parents, but I suspect that's more the gist of what that distinction is.
And that makes a lot of sense too, the fixing versus the ameliorating, making it better, being able to live as a person with these disabilities rather than removing the disability completely. That makes complete sense. Thank you for your comment. So Dr. Bischoff says transitioning from the current education model to medical could risk moving away from the instruction in the life skills, instead focusing on access to the school and to the work. And treating the person's eyes or brain rather than treating the person. So, I mean, they're all good points. What's the right answer? Continue to deny services, or, just try to come up with another way. It's just an idea. But as we know, the rehabilitation services don't treat the eyes. They do treat the person, and that's what hopefully we'd be able to get out of it.
We have one more minute.
Oh dear, I have
Kate, go
another
ahead.
question. I'm
Sure,
sorry, I
sure.
had another
No,
comment.
you're fine.
Maybe this is just launching us into something else, but Jennifer, I would suggest to you that we think completely outside the box. Right now,
I'm ready.
Okay, medical model or educational model or
I'm
social
ready.
model or cultural model. Maybe there's something completely different that nobody else has thought of, because what we really want is for people, individuals, children, adults, to get the services that they need and to have it supported financially, period.
Right.
So
Right.
let's see what we could do about taking your ideas and the work that you've already done in this area, and then just blowing the boxes out of the picture, so that maybe we take pieces of each one and create them ourselves. So that's your next job.
All right, Kay, I'm ready. And I put my email in the chat box, so please keep in touch. And anyone, if you ever have any ideas or other comments about this, go ahead and shoot me an email and we'll see what we can do. Creating something new. Thanks, Kay. Really, really a blessing to have you here. Thank you.
Thanks very much.
Thank you very much.
Thank you, Dr. Perry. It is 2:00. So stay tuned. You'll be receiving more information regarding our January speaker, who is Dr. Shofeng Li, excuse me. He's an associate professor in Foreign and Second Language. January 21st is our next presentation. So I hope everyone has a restful and safe break in between semesters. Thank you for your time as always. Thank you, Dr. Perry.
Yeah, thank you for having me. It was a great time. Should I log off?